everyone, and welcome to Grab Chat. My name's Jo McNamara, and I'm joined by fellow host Noel Joel Anderson.
Hi everyone.
So we're here in the pod box at UKIO 2025, and we're joined by another amazing guest. Would you like to introduce yourself, please?
Oh, thank you, and thank you for having me. My name is Melissa O'Neill. I'm an advanced practice radiation therapist from Canada. I hail from the other London in Ontario, and my specialties are in palliative radiotherapy and stereotactic radiotherapy.
And what brings you to UKIO?
Actually, I did my master's with Sheffield Hallam, and through our mutual friend Melanie, who was my academic advisor for my dissertation project, which she has sort of followed along and I've presented. So she, in her planning capacity, offered the opportunity to speak here. So I came to present in the clinical oncology stream on my work on diagnostic CT-enabled planning.
Quite a good university, Sheffield Hallam University, isn't it?
I might be slightly.
I don't know, I should get like a shirt or something now, right?
Yeah, tattoo. Yeah. Melanie hasn't told you about that one yet.
No.
So tell us a bit more about your dissertation.
Yeah, so we essentially built on the foundational work, I'd say, that a couple groups did, primarily in Australia, looking at using pre-existing diagnostic CT scans to plan simple palliative radiation treatments. So this is it's important to note, a very limited context and setting. And initially we were looking, specifically at conventional parallel opposed pair, direct field, sort of palliative treatments, very conventional dose fractionations, but essentially asking the same question that patients ask me all the time when I'm consulting them, of when I tell them they need to go for a CT sim and they say, I just had a scan, why do I have to do this, right? So our question is, they just had this scan. Is this scan appropriate? Can it be dosimetrically used to plan an appropriate treatment? Is that treatment delivered matching what is expected? And is it feasible? So we looked at that using CT scans that were 28 days old or less. So we kind of deemed our acceptable age range just to minimize the risk of any significant change, interval change. And we use that for patients who are coming for same-day simulation and treatment, and randomize them either in a 1-to-2 fashion to either the sort of business as usual workflow, time them from the time they checked into their CT appointment, the waiting period while the planning and quality assurance was done, and then stop the clock when they received the final dose of their treatment. And then for the other patients, we used the diagnostic CT, so everything was done preemptively before they arrived. They started their clock when they arrived for their radiation treatment. So we found that the conventional arm, the business as usual folks, spent just under 5 hours at the cancer center, just consistent with our data and previous audits. And then we found that the diagnostic CT folks spent just under half an hour. So it was a significant time reduction, and that actually translated in a secondary endpoint of patient acceptability. We really expected things to be quite similar, but it fleshed out that there was a significant clinical or statistically significant reduction in time burden for the group that had the diagnostic arm.
It's quite a big effect if you think, not just for the time, but parking, childcare, all those other factors that maybe not everyone would consider normally.
Absolutely. When you take that sort of zoom out step and you look holistically, right? Financial toxicity, you're mitigating the number of visits, the time spent at the cancer center. And it's relevant for patients, but their caregivers as well. Yeah.
And I suppose for palliative patients, not necessarily that they are coming to the end of their life, but time is more important to them.
Time is extremely valuable, right? And to spend, when you have a limited amount, a finite amount left, to spend 6 hours at a cancer center, or to be able to come in, do your treatment and get on with it. And it's not only, we primarily looked at the time that people were spending in the cancer center, but I think this workflow has the potential to expedite how quickly people get onto treatment. Yeah. So the faster obviously you get in your treatment, the faster you can potentially experience relief, right? So circumventing that bottleneck that often occurs in getting people through CT sim.
From your findings, what have your colleagues or other radiation therapists or oncologists said about what you found out, basically?
So at our center, people were quite enthusiastic, I think, overall. So what we've done is, after the trial period, we've implemented this workflow. We have fairly strict eligibility criteria just to ensure the success of it. But yeah, it's part of our routine workflow now for that limited eligibility criteria folks. We have a very large catchment area, so we have patients who are traveling up to 3 hours.
Right.
So for people coming from these far trips, it can make a significant difference. We also recently did a Delphi consensus project with other places globally, Europe, Australia, the US, who are using these workflows, and hopefully published. It's in for publication and review right now, but hopefully we'll have something to come out and also at CARO, which is a Canadian conference, but just basic pragmatic implementation guidelines. How do you select your patients? How do you select your images? How do you implement the workflow? And how do you train your staff?
Can I ask a slightly off-topic question?
Yeah.
What makes you so passionate about this cohort of patients?
I think it's working. I work in something called the Rapid Response Clinic. So I see patients who are referred in this expedited pathway for symptoms, right? These are people who are coming in pain, focal neurologic compromise, bleeding, urgency. And I think in working with that cohort and seeing how much of a difference getting onto treatment quickly can make, it's settled in there, right? Like it's something that, I am passionate about. And it's not just for the symptom relief, which is obviously important, especially in certain indications, right? Hemoptysis, you give treatment, you can expect improvement quickly. But I think it's also for the agency that the patients feel when they know that they come and that day they're doing something to help themselves, right? I see a lot of folks as well where they have an urgent indication for treatment, but it's also a very new diagnosis. So I see the understandable deer in the headlights, right? Where they may not have all the answers, the information hasn't necessarily been contextualized. And I'm in the same sort of philosophy that is if I have a problem, I will feel better the moment I'm taking an active step and involved and has some autonomy in improving the situation. So even though in this population, improvement and hope is something that is reframed and different than in other populations, I still feel very passionate and strongly about giving people that. Yeah.
Brilliant. Thanks very much for coming on.
Thank you very much for having me. Yeah.
Thank you so much.
Thank you.